Welcome everybody to a webinar with Innovacer on the new normal and new connectivity, enabling technology, unified data, and patient-centered care. We're going to have a lot of fun today. We have some really good speakers. We have Manish, who's the former VP and Chief Architect at Kaiser. We have Mike Sutton, who is the Chief Technology Officer at Innovacer, and he was the former Chief Technology Officer at Kaiser. And what he tries to keep quiet, but I always blab it out, is he was also the architect for the CIA before he joined Kaiser and decided to get at real complex data when he dealt with healthcare. And I'm Dr. Paul Grundy. I'm the founder of the Primary Care Collaborative, which led the patient-centered medical home movement. I'm the author of Provider-Led Population Health, and I'm pleased to be now the Chief Transformation Officer at Innovacer. I'm known as the godfather of the patient-centered medical home, which is a long, sordid story, but we'll get to that some other time. Thank you all for joining, and we'll go to our first slide. And Mike, why don't you give us a little startup here on the current landscape?
Thank you, Dr. Grundy. So, yeah, I thought I'd just put this first slide out here just to set some context of, the topic of, that Dr. Grundy and Manish and I will be talking about today. And so as we all know in the healthcare space, we've spent the last decade, digitizing our records. The meaningful use, regulations came out, and we've had this evolution of digitizing, and no matter how painful it was, we have created a lot of information. And I think there were a lot of growing pains as we kind of put in these transactional systems. But we've got some clear leaders in this space. Certainly the Epics and the Cerners and the Athenas and ECW. There's many platforms out there today that are doing the transactional and encounters and episodes in the healthcare space. Kind of coincident with that is we've also had some reduction in the number of infrastructure plays that are going on. There's three clear cloud leaders now. Apologies to all the others who are still out there. There are other cloud alternatives, but by far the predominance is with the Amazon folks, the Google folks, and then Microsoft Azure. And so what this has created is kind of this perfect storm. And what we believe, and many people in the healthcare space will agree with, is that we've created the next episode or epic or era is now, how do we take this data and get the promise that we had of putting in all these transactional systems and the pain the physicians had to go through and the IT staffs of getting these things in? How do we take advantage of all this information? And so what's evolved is this intelligence layer that's shown there kind of in that second row coming down. It has some of the capabilities that are in there, but what we want to talk about is how are these organizing principles in this intelligence layer evolving as we learn better how to interoperate with the transactional systems, and then how do we then get to the promise of those experiences? Because I think most of us will agree we haven't hit the nirvana of where we have all the data around a patient they have access to. It's been democratized, or Todd Park used to say, the data hasn't quite been liberated yet. How do we get to that point where we do have those experiences and kind of get to the really sweet spot of actually having the machines do some of the harder grunt work for us? And so, Manish, you're just coming from Kaiser Permanente.
That's right.
And by the way, welcome to Innovacer. Maybe you could talk a little bit about what some of the challenges are in kind of managing this landslide of data coming in.
Next slide. Take us to the promised land, Manish.
Yeah, well, as Mike pointed out, right? Epic has its own relational model. Cerner has its own relational model. You look at the number of systems that get involved in providing both the payer side services and the provider side services, each one with its own unique relational model. And then you are faced, at the experienced tier, you're faced with the challenge of unifying that data in a manner that is consistent, that is interoperable, that can work with ETLs, that can work with APIs. That's a massive challenge. The good news is the three infrastructure cloud players that Mike talked about, each one of them is focused on developing a healthcare model. What is unique and what I like a lot about what Innovacer has to offer is a cloud agnostic model that can serve the various needs, whether it is ETL, whether it's APIs, whether it is delivering experiences, being able to unify the underlying data that comes from many different systems, building that unified tier so that you can deliver the experiences, you can deliver your financial reports, you can deliver your regulatory reports. That's what becomes really interesting about the platform. And just a step further there, part of that has evolved through the regulations that have come in. If you look at FHIR as an example, the FHIR standards that have come in, those are great for APIs. Those are great for delivering experiences. But how can we take that model? How can we take the FHIR spec and build a data model that can begin to evolve and serve other needs as well? And that's where the platform begins to shine. Back to you, Mike.
So, Mike, challenges in using data, and you've begun to cover some of this as well. And let me know when you want me to go to the next slide as well.
I just wanted to kind of take your comment, Paul, about what you said. Certainly the work at the CIA was, was certainly massive volumes of data, at very high velocity with, new transactions, terabytes and terabytes, if not petabytes of data, per day. And there was a wide variety of the data, because, we get feeds, open feeds, open source, we'd get, kind of clandestine sources as well. And, but the one thing that was good about that data is the data was very discrete and stands alone. What I have found, and I was on a panel last week with some CIOs in the healthcare space, and one of the words that came up that kind of typifies what's unique about clinical data is that it is semantically sensitive. That for example, lab readings are very sensitive to the condition that the body, the human, was in when it was tested. And so even though the column on that database says whatever it says, it doesn't, unless you combine it with other information to put you in the context and the semantics of the situation. Was the person dehydrated? Were they fasting? All those types of things. There's a lot of interdependencies on the context of that data. And so one of the terms that evolved from semantic sensitivity was this idea and the need for us to be able to really get to the place where we can rapidly activate this data and use it for the things that Manish talked about. Is it's got to be normalized from not only a syntactic perspective, and that the ICD code is the ICD code that's in the current table, or the SNOMED code is correct. It also has to be able to have the semantic normalization so you can use that data within the right context. And that, to me, is what makes the clinical data, integrating claims data, a little more complex, perhaps a lot more complex than, say, doing financial transactions or in my case, counterterrorism transactions. So,
and Mike, what's interesting about that is you look at the current landscape of how healthcare organizations address their data needs. And typically what ends up happening is each system of record, whether it's your EMR, whether it's your lab system, whether it's your radiology, pharmacy system, each of these systems of records have hundreds, sometimes even thousands of custom-built pipelines coming out of it, each serving a specific need, versus being able to pull the data consistently with context into one data distribution center that can serve multiple needs. I think that is so very important. That's where the industry is headed.
Yeah, that's a great point. And not only on the transactional side, but in fact, this is probably a good segue to this slide, is that the way we've dealt with this over the past, as we've been getting this transactional information, there's been a pop-up of of data warehouses. You know, many of them calling themselves the enterprise data warehouse, but they really are not. What they really are is they were built generally, and I'm not saying everybody did this, but I think maybe some of our experiences at Kaiser Permanente were we built application specific data warehouses. Like we had to do, you know, clinical data reporting, we had to do claims reporting, we had to do pharmacy reporting. And so we kind of took that requirement and then worked backwards. So then we created a data model that, and I think we would all admit from a computer science data management perspective, all data models have a bias built into them based on the use case that they're trying to solve. And then we go back and then we go further left and we forage for that data. And what we'll have is a lot of analytic solutions that may be reporting some of the exact same measures, but because of the different biases and contextual use of that data will give very differing results. And to me, this drives the need for a common view and a common model to use and display that information.
So
I can keep going, Paul.
please do. Data sharing behaviors are changing. CMS rules. I mean, how is government in its dealing with trying to make data more interoperable going to begin to really impact us and maybe make some clarity for us as we go forward in 2021 and 2022?
Yeah, I think what is interesting is the fire specs that came out were a great start. The challenge is it only addresses so many data elements, where the data set is fairly large in the healthcare setting. So what FHIR does allow us to do is to take that approach and start to build data models that align with that approach, with the intent that you're making it extensible, with the intent that as the spec evolves, you're able to take the specifications and roll that into that extensible data model. That's where the industry is headed. That's where organizations ought to focus on ensuring that they bring in a platform that is built on those constructs, that is built on those principles, so that even if the regulations come in a bit slowly and they trickle in over a period of time, you're well set up so that you don't have to rework your data ingest pipelines. You don't have to rework your data acquisition pipelines. So that's really where things are headed. Mike, anything else you want to add?
Yeah, I can't agree more that, you know, by adopting these APIs, it does allow us, you know, payers and providers alike to create an architecture that is more modular, more extensible, and doesn't require, you know, tearing out the whole kitchen just to put in, you know, a hot water pipe or something, to put in a new application. And so it is going to be fabulous. The other thing I would add is I know you two know this, but I spent 8 years in the hospitality business back during the Open Travel Alliance in the early 2000s. And what happened in the travel business, as everybody on this call is aware, you know, the industry was revolutionized. And it was revolutionized because now, I mean, I don't know the last time I didn't book my own travel, including, you know, the automobiles, the hotels, the airlines, and then in my particular case, booking a cruise. But, you know, it was very humble beginnings when the Open Travel Alliance was formed, you know, by a bunch of folks at Expedia and Travelocity said, we have an idea. And it started out with 4 application programming interfaces. Now, granted, travel is much less complex than the healthcare space, but kind of to your point, Manish, that the FHIR resources, you get the critics today, you guys say, oh, it doesn't solve for everything. Well, we started with 4 and it transformed the entire industry. And some of the specifics I remember in that transformation that I think is very useful in a possible transformation in the healthcare space was when you produce these APIs, there's a new level of transparency. It was back in the olden days in the travel business, you know, the price you paid was, well, it depends on who you talk to. And it's because there wasn't this transparency, and business models changed that, that transparency had to happen. I think there's some of that could benefit the healthcare space as well. I was on a call earlier with a couple luminaries in the IT space. Chris Ross from Mayo Clinic and John Glazer, professor at Harvard, and a big conversation came up about trust in the healthcare space. That is such a key part of the relationship between the physicians and the patients and the people delivering care. Well, to me, one of the next word after trust is transparency. And so I look at this as being a big part of kind of helping transform the business as well.
So the current administration has really moved forward actually with this, and I worked at rather senior roles in all the way from starting with Carter all the way through Clinton, and have stayed really engaged. I helped write some language in what became the Medicare Modernization Act and also in the Affordable Care Act. So in talking to some of my friends that most likely are going to reoccur in the new administration starting in January, they're going to be focused on this, this is going to go forward from everything I can hear, and I think probably you both hear the same thing. So CMS, patient access and interoperability. Again, from my perspective as a clinician, we really need to focus also on making this a whole lot easier for the clinicians and the practices to begin to really have a plan for every patient if they're going to proactively manage a population. Comments, thoughts from either of you on CMS patient access and interoperability rules?
I'll start here. I'll start on this one, Manish. So again, to me, this is, quite a genius move from CMS to get these APIs published. We're seeing a lot of our customers, particularly in the payer space, because that's where the current regulation is focused on, for starting in 2021. But I kind of like to, it's not unlike gravity. Not only is it the law, but it's a really good idea. This will help accelerate, the IT architectures in this particular space for what Manish was talking about earlier with the data sharing, as well as, kind of internal application development. Kind of what the cloud has done for the infrastructure piece in IT. To me, as we start providing APIs, you get that same level of kind of efficiency draw in your development community, because now the developers, the data scientists, the data analysts, if you believe what they tell me, have told me over the past, is they spend 70% of their time looking for information. Can you imagine an environment in a world where there's these published, 146, current fire resources under version 4? That's a shopping list that you can almost immediately start programming from, and there's already been some, API toolkits out there for developers. This is going to speed our ability to kind of thrill our patients and members with data that we can make available to them. And I know, Manish, you were leading a lot of the efforts at Kaiser in this particular space. I'd love to hear
it's very interesting. A couple that really excite me is under the middle column, the first one that says implement a patient access API. We've got requests while I was at Kaiser. We got requests from Google. We got requests from Apple. And the request was as follows: that we, Google, have employees that are subscribed to the Kaiser plan. We, Apple, have employees that are subscribed to the Kaiser plan. We would love and our employees, our Google employees and our Apple employees have given us consent, okay, to go get our data and make use of our data for building out a variety of different applications. So think about it. You as an individual, you own your data. In the past, access to that data, you literally had to go into a facility. They would burn the data on on a disk. Subsequently, it was a thumb drive. But again, it was a fairly arduous process. With the regulations coming out, under 5 minutes, you have your data. You have access to your data. And by law, if I, as an individual, give Mike the consent to look at my data, and I let Kaiser Permanente, who's my care provider, let them know that I've given Mike the consent, then they are obliged to share that information with Mike. Just think about the possibilities there. Just think about the innovation that can occur in that space. So that is one that truly just excites me quite a bit.
Yeah, great.
So I have spent quite a bit of time working with the Danes, starting about probably 20 years ago. And I would say probably about 12 years ago, they passed legislation that requires all of the information that is generated into the health system to be sent into a central repository. And you, the patient, have access to that data within X number of hours after it's been generated, which means that you have complete access to your records. Your GP, by the way, has access to that too, if you allow them to. And if you don't allow them to, then you're going to pay 10% of total costs. So you and your GP have access to everything that happens to you. And it was interesting. They took a year out to sort out how the security around that would work. And so they set up legislation that basically said that if you're in an emergency room and you're in a coma, you can break the glass and anybody can access that record if they need it. But if they do that illegally, they will lose their license and they'll go to jail for 5 years. And as far as I know, that's never happened. But that allows any primary care physician to cover for any other. That allows anybody you're seeing to have immediate access to your record if you're there and give them permission. And it allows you to really monitor your health. I mean, it's just phenomenal what you can do with that. So I think I took Kaiser over there about 10 years ago, and Dartmouth sent 2 researchers over there to look at that from the VA. So maybe we've learned some of that from what the Danes are doing. So artificial intelligence, that's a word we hear over and over again. And I think, thank goodness, we've left the age of information and we've entered the age of intelligence. I mean, I think that with the ability for AI to look at patterns differently, data is going to do for our minds what X-ray and images has done for our vision in healthcare over the 40 years of my career. When I started, an ultrasound was shadows, and now it's just an anatomy textbooks picture. And to be able to have at the point of care a plan for every patient, to be able to engage your patient with that plan, and to understand the patterns that a machine can do that we can't do, I think it's going to really revolutionize care. Now over to you experts to talk about it.
Yeah, and I think you look at the application of AI in the healthcare space, on the payer side, on the provider side, there's just so many opportunities. I'll give you one to think about in the call center space. AI has been evolving so quickly that when a person calls in, a member service representative picks up the phone, or it's a chatbot. Increasingly, we're moving towards chatbots. But a member services person picks up the phone and is talking to that member. That member is inquiring about care and coverage and what they're eligible for. But based on the words that they use, the AI systems are able to detect the intent of the call. And the intent really is that this person is concerned about the cost of healthcare and is potentially looking to see ways to reduce the cost. Not so much to understand the coverage, but they're going through some financial challenges, and as a result are calling in to understand what plans or what options are available to them. They may not explicitly call that out, but AI platforms are now able to detect the intent of the caller by connecting the dots in the words that are spoken, the intonation, the pronunciation, and the fluctuation of the sound, fluctuation of the words that they speak. And based on that, is able to, in real time, not after the fact, but in real time, pop up a decision support on the member, on the representative's screen saying, hey, you may want to ask this individual about X, Y, and Z. So AI is becoming more and more mainstream, not just on the payer side, but also on the clinical side, where we are building symptom checkers. And think of medical symptom checkers that are becoming more and more intelligent because they're able to pull in more data about you from different sources that were not available in the past. And as a result, as you go through the symptom checker, it's no longer a decision tree. It is really based on the questions that you answer and how you answer them. The next set of questions are not necessarily based on a decision tree. They're absolutely driven by AI. So you will see more and more of the patient experiences, of the member experiences infused through AI. Back to you, Mike.
You know, with
Yeah.
with manic depressive disease, AI can, with extreme accuracy, tell whether you're manic, depressed, or neither of those with a 2-minute conversation. Just how you're streaming your words together. So I mean, it's really gonna I think provide some assistance to support that healing relationship of trust between a patient and their clinician.
Yeah, and I'll just mention one other thing, that radiologists, when they look at the images, they do not have the full context about the patient. They typically look at the image and dictate the reading or type in the reading. Being able to look at that unstructured data, that textual data, and pull out keywords and connect it back to the patient history and be able to say, maybe this is what's happening with the patient in real time is so powerful. Doing that manually today could take up to hours. So
Yes.
Yeah, these are great points, and I thought I would just add 2 other points. And it's probably taken a bit of a risk, but I put kind of the AI applications in 3 categories. And Manish and Dr. Grundy certainly talked about the 2 cases, kind of the business, the process of healthcare, the practice of medicine and how the advances there can help. But the other one, and this is of course kind of the nerdier one, is but also in the development and curation of the data, is because a lot of content, and Paul mentioned this earlier, that being able to understand the relationships between these data and how the data is better managed and even protected benefit a lot from AI and machine learning type techniques that are in practice today, and there's many evolving. And kind of Google's a great example of that. If you use that Google Assistant, I mean it's looking for relationships in piles and piles of data. And the other thing that I'll just add on to this is that these AI techniques, a lot of people kind of, oh, that's kind of voodoo magic type of thing. Really, a lot of the algorithms have been around for 2 or 3 decades, and it's just now that we're getting the compute capacity and the data storage capacity to be able to implement these things. It's just that exclamation point behind explosion, I think, really does typify that the new normal in this particular space could become very interesting in the next few years. It's a great time to be in this space, in my opinion.
yeah, and we are able to today predict in our urgent care clinics. We are able to predict with a 85% accuracy when we can see the volume of patients coming in go up and go down. And based on that, adjust the staffing levels of nurses and doctors. What is very interesting about AI is that the models that you develop, it's not a one and done thing. Often I hear execs say, hey, why don't we build an AI model for this? And they look at it as a project. It is really a continuum, and a model that is a champion model today and gives you an 85% accuracy, well, tomorrow with additional data that comes in, may no longer be the champion model that you, again, auto AI, the ability to constantly apply different algorithms to the data that you have and have a champion emerge is the new trend. And the key here, again, is the underlying data and the accessibility to the data and being able to apply these algorithms on an on-demand basis is so key. And that's why a platform-based approach to making this data available so that you can actually do real AI and not focus on bringing the data in and contextualizing it is so much more important.
And that data that's coming in is really fascinating because it's pulling in search. How many people are Googling for flu? How many acetaminophen prescription or things have been bought by Target? I mean, that's what gives you some real clarity as to what you're going to need to staff at 8 o'clock in your urgent care center.
And not just that. I mean, you're bringing in weather data to say, hey, is it raining today? If it is raining, this is what it's going to do to the volume of patients coming in. Is it the flu season? Is it the spring season? So there's just so much more that you can bring in. Where are you located? What is the zip code +5 demographics around that look like? So yeah, great points.
So we have our first poll here. So I won't see the answers because I'm managing it. So Mike or Manish, you need to tell me when the answers are popping up.
Okay.
I'll give you a couple more minutes and then we'll close the poll and see what we got. Okay, let's bring up the results.
All right, Paul, there shouldn't be a surprise. What are the primary challenges that organization faces in implementing AI? It was 37, number one was 37% said the lack of high quality and uniform data to run those models is their biggest challenge. Second is limited understanding of AI use cases. Third is lack of AI talent. And then the last two were unable to find the right tech partner, which I think Innovator can help there. And then also not ready or able to consider AI at this time.
Okay, well, thanks you guys. So, but what does AI mean? The path from supervised machine learning to intelligence. Mike, you want to start that off and follow up with Manish?
Yeah, this is kind of going after one of the questions of theirs is how well what does AI really mean? And it is, it's really when you get into it, it's actually not quite as complex as the computer scientists actually make it out to be. Some of the early models, and particularly around data management models, they're simple logic statements. Like some of the expert system type rules is what they used to be called. They're simple statements like, and this is right out of some of our models we use to clearing the data, is that a lab test date can't be before your birth date. Well, believe it or not, that is an expert rule. It is a rule that somebody wrote. Now, that's probably one of the more rudimentary ones. But there's also more complexity, and I'll go into the examples of what I mentioned earlier about semantic understanding, is given some of the natural language understanding and natural language processing capabilities out there, if if while we're processing some data on an ingestion stream and something looks out of range, let's say a value of a medication is out of range, what machine learning does is we point the computer to some of the doctor's notes, and in those doctor notes we go through there and try to understand the context and why that medication was given, and actually look for things like, well, is this dosage even right given the words that are in there? So we actually, that's using, you know, computer natural language understanding to create context to make sure that a structured record that is coming from the EMR, or in this case a pharma system, is accurate or not, or whether that is suspect data that should be reviewed. And so that's kind of on the far sophisticated side, but I would say, and maybe Manish, you can kind of validate this, I'd say well over half of the AI models that I've seen in use today and in production are much more of the simpler types, you know, being, you know, kind of expert rules, or perhaps, you know, some, you know, least squares linear regression type models, and really not getting in this to sophisticated things yet, although I'm sure they're coming.
Yeah, I think AI in the space of clinical decision making is probably still evolving. I think there are other domains that are a lot more safer once you may want to start with. I gave the example of call centers. That's a great example to begin to instill AI again on the member side, not the clinical call centers, but the member call centers. Another area to pursue is claims. Within the space of claims, you may be interested in understanding why, as a payer, why is it that many of my members are seeking care outside the network? What are the data points that allow me to understand that behavior, and how do I change that behavior and reduce my cost? So there's obviously AI that can play in that space. AI in the context of a symptom checker, and there are many. If you go look up a clinical symptom checker, WebMD has one. There's a company called Ada Health that has one. There are so many companies with some phenomenal symptom checkers that are AI infused and model infused. That's another example. The ability to do billing more accurately and ensure there's not a revenue loss by looking at the doctor's notes and correlating that back to ICD-10 codes to say, am I charging, you know, if you're sending a report out to CMS and you have a capitated model for how much you can charge for a patient, am I ensuring that all of the ICD-10 codes are covered in the CMS reports? Am I missing something? There's just so many opportunities to be able to use AI in a safe and a secure way and learn from it before you go into the clinical settings.
So I was asked to do a lecture at the Singapore Medical Society about a year ago, just before we clamped down and couldn't travel anymore. And I wrote a 5-page sort of summary of what AI was, what the different elements were. And I'll ask my team to help send that out to the folks that are on this. It's sort of an encyclopedia. It just describes the different elements. But I tried to send that ahead of my talk because, you know, docs, 7,000 docs, and probably 20 that would really understand what we're talking about with AI. So if anybody wants it, I'll be glad to send it to you. AI in the big picture, I think the patient at the center. I mean, I think from the standpoint of the patient, an example that I like to use with what we're trying to do at Innovacer is that a woman who works with 3 kids, and if you look at patterns, you know, the most likely time that they're going to respond is after 8 on Tuesday. I mean, that understanding and how they look at the data and how you follow up with them is the way Amazon shops you. And I think that's helpful to patients to be kind of reminded and interacted with. Another example is in Denmark, if you have a chronic disease, you're given a dispenser. When you dispense the pill, the system recognizes whether you've taken it or not. If you don't, you get a choice of a bird chirp to remind you. And if you still don't, you get notified that you're going to be taken out of the lottery. But to have tools that can follow up and remind you and engage with you in different ways. I mean, there's just all kinds of examples. That's just one, but
Yeah, I would just add, Paul, you hit one of my favorite topics, and it kind of touches on what Manish was talking about is, we don't really need to start in the clinical space in all of this. If you think, you mentioned Amazon, I mean, in the consumer marketing space, there are models that are out there that can help identify what our behaviors are, what our behaviors will be. And, at the end of the day, patients are consumers. We're consumers of the healthcare system. And I think there's a lot of possibilities, once we kind of merge the two disciplines of kind of, consumerization and then kind of clinical data that's, in a format that's understandable and can be used correctly. I think there's great models that will help people, kind of build a better healthy lifestyle, make some of the better choices. I use the word manipulate behavior, and everybody called me a CIA guy, but maybe manipulate's the wrong word, but actually help people, make some of the right choices. This is, just like Waze tells you to turn right. There's plenty of the technologies that do that can be helpful in this particular space as well. And that's got to be a thing to come.
And it's quite fascinating you mentioned behaviors, Mike, because while at Kaiser, we were innovating on a diabetes management tool that was incented at changing behavior. And the ability to change behavior depended on multiple different data points, multiple different factors. And then knowing you as a person, knowing your patterns, and then really sending you soft nudges to change your behavior. I think you're spot on. That's the next horizon. That how do you, get proactive about this and change behaviors so that your clinical outcomes are a lot better.
yeah, understanding the science of behavioral economics, I think, is just going to be immensely important because, we as human beings are not rational for long term. If we're given a choice between a Hershey candy bar and, $100 more a year later, we're going to take the short-term reward most of the time. It's the way we're set up and our brains are designed. We learned at IBM when I was there that it takes about 6 months to create a good habit, and it takes about 3 days to break it. And putting in place a reminder, a system that engages you around that. I mean, one example is, a pedometer is really helpful for somebody who's a diabetic because exercise is really good for you. And, and if that gets monitored and you have a team member that calls you if you haven't used it in 2 days and wants to know what's going on, the success rate is much higher than if you just give them a pedometer and say, use it.
Sorry. That's right. And so I think the key message is, there's just so many opportunities of applying AI. We talked earlier about the example of reducing the wait times for members and increasing utilization and improving operations in general, and especially in times of COVID, being able to predict when somebody is coming in so that you can appropriately staff up is so critical.
So when I was in Vermont, when I was at IBM, IBM was the largest employer in Vermont, and we worked with the state of Vermont in something called a blueprint for health. And we took 2 cents out of every sick care dollar and created the role of the community coordinator. And the community coordinator pulled all of the community resources together so that my newly diagnosed diabetic, they were taken and introduced to the diabetic hiking club. They were introduced to the nutritionist in the grocery store. If they didn't have a coat, they'd be introduced to Salvation Army. But all of those resources were pulled around a plan for every patient that was much broader than the clinical plan. I was at a meeting. In St. Johnsbury. I went up there and I sat in the meeting, and once a month, all of the community resources would gather. And the young Anglican priest says, "Never again will we allow a diabetic to suffer an amputation because we don't have a plan around the patient. And what I saw happen over the next couple of years there was a 60% reduction in the complication rate of diabetes, 60% less blindness, 60% less amputations, right? 60% less renal failure. But that concept of social determinants of health and the concept of how you integrate that into your plan, I think is just immensely important. When I was working on delivery redesign for primary care in England, and I went to see how they were beginning to set up their medical homes, their medical home had the guy in charge of fuel oil, in charge of food, that were engaged, in the comprehensive plan of the patient. But I mean, so much is important to pull in and engage. And one of our another story, one of our clients, we began to see an uptick in hypoglycemic hospitalization events for our type 2 diabetics. We began to see that in 5 or 6 zip codes, and we began to see that in the last few days of a pay period. They were running out of food, and hooking them up with a food bank, getting them engaged with, with tools like Aunt Bertha or United to really pull together broader support than clinical support. Thoughts from you, Mike and Manish?
I'll go to the technical part of that. And you mentioned Unitas, you mentioned Aunt Bertha. There's many other resources out there. And the challenge from a technology perspective is how do you make sure we get this just like claims data being integrated with and unified with the clinical data. We need to bring at the same level this type of community type data in this model. And how do you identify that this person is in this particular persona? I mean, certainly zip code is a way to do it, but make sure that we can get that mapping so we have an accurate model with the data to be able to present to the folks that are creating the algorithms or the applications that will be providing this care, as well as kind of that last mile of how do you communicate back with those. You mentioned that pastor, the community services. There's a lot of new capabilities on that, but in order for that to work, we need to be able to communicate with that. And that's why we'll just go back to those FHIR APIs. That is the way we're going to communicate with those community resources, because it is a private way to do it. It is a secure way to do it. And we'll be able to get the right information to, in this particular case, not necessarily the point of care, but the point of community. And how do you get it into those environments?
Yeah, and if you are a payer or a provider, and if you're a CFO, man, this is a golden nugget. I'll share one very interesting data point. It is not uncommon for 5-6% of your population to use up 60% of the beds in a hospital.
Yep.
Not uncommon. And what is unique about this 5-6% of the population that uses up 50-60% of the beds is they all have social determinants associated with them. I often bring up the story about a patient that came into one of the Central Valley facilities, and this patient had a social determinant. She actually had challenge with mobility, so she was in a wheelchair, and she was also obese. So the unique thing about her is the wheelchair was supersized, and the on-ramp at the facility could not accommodate her. That was on a Friday. So she went back. On Tuesday, she was admitted into ER, right? So the ability to, our systems, our EMR systems are still not very good. We are good with ICD-10 codes. We are good with diagnosis codes, but we are not yet there with being accurately able to capture the social determinants that have a huge impact on clinical outcomes and correlating that back to your medical record. And so Mike talked about resources that are available for folks with social determinants. For example, they may not have access to good food. They may not have access to transportation. The list goes on and on. Being able to understand that, being able to bring resources like Unite does to help with that, and being able to correlate that data on a unified platform so you can provide better care and reduce your cost I think this is a golden nugget that it's an area of innovation that many organizations are focused on.
And that really is going to take AI. I mean, what we do at Innovacer is gather information from, I think, 85 or 86 public resources, understanding of where the liquor stores are and where the grocery stores aren't, down to the zip code level. And then with that, you can begin to look at the questions, the 5 or 6 questions you need to ask down to the individual level with a quick survey to understand some of the vulnerabilities, transport, food, housing, money, etc. But when you're at risk, when you're at risk for a head in the bed, as Kaiser is, or as many systems are going to be as we continually move to at risk, boy, it behooves you to begin to understand how to deal with that if you want to be successful.
Absolutely.
Widening the lens, a regional view of social vulnerability. Yeah, I think we've talked a bit about that already, but we have huge variations in disparity across the United States and certainly across the world. But even within my little community in New York, there's just tremendous variability, and understanding some of those issues are just going to be really important. Mike,
Yeah, I mean, you just look at COVID as an example, right? The number one community that is impacted is the Hispanic community. Why is that? What are the social elements that are causing that to happen? The number one death rate is in the African American community by percentage. Well, why is that? What are the social determinants that are causing that to happen? So there is disparity, social disparity, and understanding that, and really bringing in the necessary resources. Dr. Gundry talked about the 30, 40, 50 resources that we bring into the platform that can help you better address some of this is going to be so critical.
And then the one thing I would add is kind of in the implementation of a number of these social determinants, and to create that view, is certainly zip codes are great, street addresses are great, but it's even better when you can get your patient or your members to contribute some of their own inputs, and you can do that through some simple survey questions to actually create a much more personalized version of that, without violating privacies as well. And so I think this is going to be a field that's advancing, and there's certainly a number of capabilities that exist in this area as well.
Yeah, I was blown away. I went and spent some time in a clinic that was using that resource, and then had a little iPad that they handed out to their patients. This particular one was in Iowa, and I sat and asked the patients what they thought of this. I thought they would be concerned about privacy issues. They were they were all excited that their provider, who they trusted, right, cared enough to ask, right, to ask what are your issues in my helping you get better. But it was really honing down on sort of at the zip code level, honing down on the 5 or 6 questions that needed to be asked, given the knowledge that the AI could provide, an understanding of what would be the most likely questions that need to be asked in that population. That really helped, I think, make that possible to do. Poll number 2, and we only have like 6 minutes left, so I'll leave this open for a minute, and then we have just a couple more slides. We're getting there, guys.
And while we're waiting on the poll, Paul, is what we're seeing in dealing with a lot of the geographies we're in, where we have the pleasure of serving innovators in both the payer space and the provider space. This concept of the data networking halo effect that if you can close that gap between the two parts of the healthcare system, the payers and provider parts, and then have that third leg of community in there, is you're seeing a tightening of that information, or a tightening of that those business processes, and efficiencies being created in these spaces that benefit, and the payer and provider world is, somewhat contentious because one's paying the other, but you actually find a very mutual beneficial effect of getting this data closer and closer. There's less errors, everybody benefits from that. Processing time gets reduced. There's better information, better good time about that being reduced. And then there's just better information available, so you can better decisions can be made on both, whether you're on the provider side or the payer side. And this is happening today in many of the geographies where we kind of have that that opportunity.
Yeah, I was sitting in a practice in Michigan, in central Michigan, and the doc said, my best part of my day is when I have a patient from Blue Cross Blue Shield or Humana, both organizations we were supporting, because it saves me 3 minutes of time. I have in front of me everything I need to know to best serve this patient and to best serve the contract this patient has. Yeah, it's real cool.
So we have the results of the poll, Paul, and
give us the results, Mike.
All right, 55% increasing recognition that such collaboration is essential. That this is, how do we say payers and providers are collaborating? It's when they start seeing some of these benefits that we just mentioned, that gets to the CFO and the chief operating officers in these environments. The second one at 33% is that they may each have their own separate strategies. Is the second one. And then kind of the bottom two were they don't see payers and providers collaborating. So we're actually seeing people are not seeing that they don't want to collaborate. And then the other one is it's the other guy's job. That's a less than 5%.
Yeah. Well, that's interesting. So thank you very much for answering that, everybody. Augmenting the human experience with technology. Wow. Manish, why don't you start with this? Because you've been working on this a lot at Kaiser.
Yeah, it's quite fascinating. My mom, she is diabetic, and a couple of years ago, she would call in the Kaiser facility once a week and provide her glucose readings. The nurse that was taking the readings would write it down on the paper, then go enter it in the system. And before the doctor sees it, it's 2 weeks before those numbers are crunched and meaningful feedback is given back to my mom. With the remote diabetes monitoring, we are now able to send multiple readings, not once a week, but multiple readings in a day that get integrated into our EMR. Just an example of how technology is really having an impact on how we provide care. With COVID-19, prior to COVID-19, the norm was when you wanted to see a doctor, you would walk into a facility, or you would do a phone consult and seldom do a video consult. Since COVID, it is not uncommon, and we've seen this at Kaiser as well, to see upwards of 1,000% increase. At Kaiser, we saw a 2,000% increase in the number of video visits. And these changes, I believe, post-COVID are here to stay. This is we've talked about the right care at the right time at the right place based on your preferences. Technology is making that happen, and these changes are here to stick. So virtual care is becoming real, and COVID has just expedited the rate of change, and it is here to stay.
Yeah, I think COVID sped up what was already in progress. And we're in our very last minute. So Mike, if you could just spend 30 seconds on the unified patient record, and then I would like to thank everybody for attending, and have a good Thanksgiving and stay healthy.
And my 30 seconds on 30 seconds on this. This is pretty much what we've been talking about, is the ability to bring in all these heterogeneous, disconnected, different fragmented systems, get a unified view around that, and then let the patient benefit from that. And then you see all those assistances going on along the sides, you know, enabled by AI and speed of application development. So this is kind of the whole Innovator story, and thank you everybody for attending.
Thank you all so much for attending, and everybody stay safe and happy Thanksgiving, and we'll be in touch. Bye-bye now.
Thank you all.